Good morning, everyone, and thank you for listening. My name is Eleanor Robinson, and I'm a third-year podiatry student. Today we'll be discussing the most common surgical procedures performed in a podiatric setting. Here we have an overview of the procedures. We'll be discussing various ingrown toenail procedures using Winograd, Stadic, and B&A techniques. We'll also be looking at hallux valgus corrective surgery using the chevron, scarf, and Aiken osteotomy procedures. And we'll also be looking at hallux rigidus corrective procedures using the first MTPJ arthrodesis, the cheilectomy, and Valenti procedures. So before we look closely at the surgical techniques of ingrown toenail pathologies, it's important to have an overview of the most common etiologies of onychocryptosis. Sometimes the etiology of the pathology can influence the treatment path taken and help avoid unnecessary complications. The most common etiology of an ingrown nail is improper toenail trimming technique, mainly from rounding the corners of the nails. As so greatly demonstrated here, this can result in little spicules that penetrate the lateral nail fold, leading to local inflammatory processes that can result in granuloma and hypertrophy of the nail fold, often accompanied by the typical signs of ingrown nails, such as your erythema, your exudate. And ingrown toenails are not considered to be a self-limiting condition and will continue to cause increased discomfort, pain, and functional disability if left untreated. The Heifetz 3-stage of classification is commonly used to determine the most appropriate treatment technique, and stage 2 and 3 are generally treated with surgical management, with conservative management being reserved for early stage ingrowns and post-surgical prevention. Especially important for the patient is having a time and cost-effective treatment procedure that can maintain or improve their comfort. The Winograd procedure, also known as a wedge resection, was first described by Winograd in 1929 and has remained largely unchanged since that time. It is best suited to stage 3 ingrown nails with severe hypertrophy and granulation tissue of the lateral nail fold. A small incision is made to the lateral nail fold, extending into the eponychium. From there, the soft tissue is bluntly dissected from the affected portion of the nail plate. The nail plate is removed via an incision that extends into the germinal matrix. The procedure is typically combined with a surgical or chemical matrixectomy of the germinal matrix and nail bed. A partial nail avulsion is most often referred to as a B&A, ideally suited to the stage 2 ingrown toenails with mild to moderate nail fold hypertrophy. Only the affected portion of the nail plate is removed via sharp dissection. Again, it is commonly combined with a matrixectomy, often using phenolization to destroy the matrix. By removing the need to incise the surrounding soft tissue, healing time is promoted and can greatly reduce the post-procedural morbidity risks associated with other procedures. The P&A is also most popular with patients due to the procedure time as well as healing and aesthetic outcomes, as it can help preserve the affected nail plate. And the Stadic technique can also be referred to as a total nail avulsion, or a TNA for short, whereby the entire nail plate is excised. Incisions are made along the natural nail folds and eponychium, as well as underneath the nail plate, dissecting it from the nail bed. The nail plate is then avulsed from the nail bed and accompanied by matrixectomy. The initial incisions are sutured and the nail bed is left to heal via secondary intention. This technique is the least popular with patients, and in particular the female patients, due to the increased healing time and the less than popular resulting cosmetic appearance. And phenolization. So all of the surgical procedures that were discussed are commonly accompanied by phenolization, and phenol is a strong acid that is highly erosive. When it comes in contact with the skin, it leaves a white precipitate layer. Use of phenol has been associated with decreased postoperative analgesia due to its neurolytic effects. Typically applied for 3 1-minute applications, with care taken to avoid skin exposure. Much of the literature suggests to flush with alcohol after phenolization to neutralize the phenol and prevent chemical burns from occurring. However, some recent literature does suggest that instead of neutralizing the phenol, the alcohol simply dilutes it to a level that negates the corrosive nature of phenol. It suggests instead that the extra time to apply protective barrier to the skin, such as petroleum jelly, is worth the extra time to prevent chemical burns from occurring. Surgical interventions in ingrown pathologies have been proven to be most effective at preventing recurrence and treating more severe cases that do not respond to conservative management. When used in conjunction with phenol, it can improve post-operative pain and has a high cure, low recurrence rate, whilst remaining time and cost-effective to both patient and practitioner. Some studies suggest that the use of prophylactic antibiotic use, but there is no statistically significant data to support these claims. It is also suggested that educating a patient on proper toenail trimming technique can be effective in preventing reoccurrence on digits. Hallux valgus is a common genetic complaint that affects females more than males. When conservative treatment is no longer effective, surgical treatment can be considered. Simply being cosmetically unappealing is not considered indication enough. Surgical correction will be considered when the hallux valgus becomes symptomatic or is actively limiting functional use, or if there is significant development of the deformity. The chevron osteotomy is considered the most popular method of hallux valgus correction. It is best suited for younger and more active individuals, but success has been seen in older and less mobile patients, so shouldn't be discounted entirely. A dorsal incision is made and the distal metatarsal head is shifted laterally. From there, a V-shaped osteotomy is performed dorsal to plantar. It can be left as is or can also be fixated with a screw to prevent mal or non-union. This has very good success rates long-term. The X-rays above show a patient pre-op and 5 years post-op without internal fixation. The scarf osteotomy is a difficile osteotomy best suited to moderate to severe hallux valgus deformities. It combines a longitudinal and 2 frontal plane osteotomies that are internally fixated with 2 screws. Its inherent stability and minimal complications make this a popular choice for early weight-bearing activities, and intermetatarsal angle correction up to 5 degrees have been seen to have a high success rate. One of the main complications with this procedure is that the sagittal plane instability can lead to prolonged osseous healing and potential malposition of the first MTPJ in dorsiflexion. The Aiken procedure is a proximal metaphysis osteotomy, commonly used in conjunction with other procedures. When used alone, it is indicated for mild to moderate deformities, but can treat more severe deformities if used in conjunction with other techniques. A wedge of bone at the proximal phalanx is removed, and the digit is then straightened laterally. There are various fixation methods available, but Kirschner wire has been seen to be considered the most biomechanically effective and also the strongest method of fixation. Although it is considered an unpredictable technique when used alone, it is useful for correcting the retrograded forces that are created by laterally deviated flexors. Postoperatively, the chevron osteotomy found an average hallux valgus angle improvement of 13.6 degrees and an intermetatarsal angle improvement of 5.1 degrees. Although it is difficult to directly compare the procedures as they are indicated differently, the scarf osteotomy has an average hallux valgus correction of 19.1 degrees and an intermetatarsal angle correction of 6.6 degrees. The scarf osteotomy also has the quickest return to activities such as sports at around the 8-week mark. It has also been shown to reduce painful hyperkeratosis buildup that was present preoperatively. There is limited credible research of the Aiken procedure corrective values, and it is most commonly used in conjunction with other techniques though not a complete reflection on the procedure itself to use such values. However, it is considered unpredictable and often provides unsatisfactory results when used alone. For osteoarthritis of the hallux or hallux rigidus, failure of conservative therapy and loss of function in the first ray can be indications that surgical management is appropriate. The Cochrane-Shumas classification of hallux rigidus developed clinical and radiographic findings to assist in classification of hallux rigidus and to determine the best surgical approach to take. The first MTPJ arthrodesis is best indicated for severe hallux rigidus deformities. A dorsomedial incision is made and the articular cartilage is resected. The level of correction is based upon the individual functional needs of the patient, but ideally a 10 to 15 degrees valgus and 15 to 20 degrees of dorsiflexion is aimed for. It is internally fixated using cross screws as demonstrated above or Kirschner wires. A cheilectomy is performed on mild to moderate deformities using a dorso-longitudinal incision. There are reports of both medially or laterally favoured incisions, but it seems to depend on the surgeon where this is placed. A synovectomy is performed and any loose bony particles are removed, as pictured here. An oblique osteotomy is performed that can remove up to 25 to 33% of the metatarsal head. The end result should be 70 to 90 degrees of dorsiflexion at the MTPJ. The Valenti procedure is a partial arthrectomy, not to be confused with an arthrectomy, of moderate to severe hallux rigidus deformities. A dorsal incision is made to the EHL insertion, taking care not to dissect the EHL, where an angular V resection is made to the distal metatarsal head and the proximal phalanx, to 2/3 of the joint height. This preserves the plantar joint space. The resection is along the longitudinal axis to achieve a total of 90 degrees dorsiflexion. This technique is shown to have up to 27.5 degrees improvement to a patient's dorsiflexion. Postoperatively, the non-weight-bearing to weight-bearing transition is roughly the same. However, the Valenti procedure does boast of minimal immobilization in the immediate postoperative stage. A cheilectomy procedure is most commonly preferred for mild to moderate cases due to its ability to preserve more of the joint space. However, it is possible to obtain similar results using the more technically difficult arthrodesis. The Valenti procedure is preferred in more severe cases due to its low complication rates, often resulting in improved patient satisfaction. And that concludes the discussion into common podiatric surgical techniques. Thank you very much for listening.